We're now going to have a panel for the next roughly half hour where you are able to ask questions of both doctors here. They will not be here for the ethics roundtable, so this is now a great chance for you to potentially ask some kind of questions related to ethics as well. With that, as people meander in and out, we'll prepare for actual questions. I'm going to start. I sensed, and feel free to deny it, I sensed from both of you frustration with the FDA. Maybe not explicitly. What can you see that would be improved at the FDA for both pre-disease and post-disease, as kind of the two of you sort of are hallmarks of that?
Yeah, I don't have to beat around the bush. I'm very frustrated with the FDA. They are sort of learning on the fly. You know that old expression, putting together the airplane while you're building the airplane while you're flying it? Sometimes it's used for genomics in general, but in this case it's really relevant. They're regulating on the fly, and it's creating lots and lots of uncertainty for both academics and commercial entities. So I think that they should continue to allow LDT. It's a technical term for laboratory developed tests, and I think they should regulate laboratory quality through the CMS mechanisms.
Yeah, I mean, it also depends based on the trial that's submitted and the group that's reviewing it at the FDA as to whether or not it's going to be approved, which the other problem is that there's not always consistency. One of the things that I have noticed recently was that when I first started this whole endeavor, actually the thing that slowed us up was the FDA, because they made us validate our device. And that took an entire other clinical trial that we weren't expecting in about 14 extra months, which was extremely difficult because then we had to present it back to them. But that being said, in terms of clinical trial designs, I think we are now seeing some major changes at the FDA. There was a drug recently developed that first in human, the first patient that was ever treated, through FDA approval of the drug for commercial use was about 15 months. And even with the immune checkpoint inhibitors, with pembrolizumab, which is a very important drug coming forward, from the time the first patient was treated until the time it became FDA approved, and in that interim there were close to 2,000 or 1,200 to 1,500 patients treated, was 3.5 years. Now you say 3.5 years is a long time, but it used to take us up to 10, 11 years to get a drug FDA approved back in the olden days. So they, at least in terms of clinical trial design, they are starting to understand. But in terms of the biomarker requirements that are needed to get the drugs FDA approved, therein lies a huge challenge as well. And like you said, they're learning on the fly. And unfortunately, certain companies and certain drugs, and unfortunately certain patients, end up suffering in the interim. I happen to have trained with the person who's now running CEDAR, Rick Pazder, who I think has made significant strides given the conservativeness of the government and the face of the FDA. But in terms of devices, we're really challenged. Yeah.
It's working. I don't know if it's working. Oh, it is? Okay. Thank you both for phenomenal lectures. I think my question is probably geared more to Dr. Green. In your discussion about diagnosing diseases and using genomes for that, do you see perhaps an overlap with social determinants, because that's gotten a lot of attraction as well? So how do you see that playing in?
What do you mean by social determinants?
Well, education, poverty, those sort of factors that influence health as well. So how do you see that?
Yeah, absolutely. I mean, I think I should have been more clear that I think I should have been more clear that maybe, our entire concept of disease is part genetic and very much part environmental. And that environmental has, at this moment in time, still an enormous amount of lifestyle, and lifestyle is associated with socioeconomic arena. So yes, all of that are fertile grounds for public health intervention. And sometimes it's, of course, the public health people, and I count myself as one, who say, why are you doing all this fancy schmancy stuff with genetics? You should just get out there and do weight reduction and smoking cessation, and that will save more lives. And it probably will at this point in time. But I love genetics, so I'm doing genetics. But it is, of course, important in the larger context to remember that not only are these things responsible for a huge burden of human suffering and one can make interventions at a different level, but that there's all sorts of interactions between the environment and genetics. So that's true too.
Oh, no, I agree. I mean, we even see it even more so. I mean, certain socioeconomic groups have a greater trend towards certain malignancies, and many of the reasons are because of environmental factors. Probably also genetic factors, obviously, but the environment is huge.
I have a couple of questions. One is directed to regarding the heterogeneity of the cancers. You pointed out that the cancers that travel and are metastasized and go to different organs are going to be different. Well, what is the status of cancer stem cells that probably might be varied?
Yeah, so in fact, some parts of cancer stem cells, some of it is pretty controversial, especially in the solid tumor arena, but I do think there are cells that have stemness. And we just actually submitted a grant, for instance, with triple-negative breast cancer. Dr. Haber's group at Harvard, that Dr. Green's probably very familiar with, has developed an assay that can pull out some of these circulating tumor cells and then pull out some of the stem cells. And I do believe that there is merit to the stem cell hypothesis, but I still think in the solid tumor arena, at least, it's pretty controversial. Like, where exactly are stem cells versus just migrating tumor cells? I don't know, Dr. Green, you may have a different philosophy than I do.
Not my area.
Yeah, but I mean, I'm also working with Max Swisher right now. We have a promise grant looking at breast cancer stem cells, and it's very difficult to pull out those stem cells. We do have certain markers, CD24, 48. We have different markers that we can pull out those stem cells and follow them. But the science of cancer stem cells, at least in solid tumors, leukemias, lymphomas, it's much better understood. But in solid tumors is really challenging.
And how far have we gone in terms of combining different antibody treatments that are directed to different immune checkpoints?
Yeah, so basically, that's big right now. So, obviously PD-1, PD-L1 inhibitors are there, but, we're combining them right now with IDO inhibitors and, a lot of other different targets of immunotherapy. It is it's here to stay. It's moving forward. Although we're still, there's two different immune checkpoints, like the CTLA-4 inhibitor and the PD-L1 inhibitors are combining together, showing better efficacy than each drug alone. Some of that, though, is associated with increased toxicity, so you just have to balance it. Immune-targeted therapy really lends to a totally different toxicity profile than targeted therapy, and so we're getting used to working through those side effects and dealing with them. But I think combination immunotherapy is definitely here to stay.
Thanks.
Yeah.
Hi, how's it going? So one thing that I noticed made a very brief appearance in Dr. LaRusso's presentation was the rapid development of proteomics, especially in clinical research. So I was just curious for both of you guys, I suppose, how you predict the rapid development of proteomic techniques, being able to derive a whole proteome off of a specific cell, that kind of thing, how that might relate to the increasing sophistication of genetic techniques as well, and how those two will relate to each other as time goes on.
You want to start with non-cancer?
Well, yeah, I'll just start. I mean, at the very basic level, as I'm sure you're aware from your question, proteins, get amended and modified as they're made. So the 20,000 genes make a lot more variety than just 20,000 proteins. So that's a huge area, and we understand it much less well. And so I would kind of only agree with your thesis that this is going to be a new complex area of discovery that's going to have its own advocates for disease association, its own theories, its own blind alleys, its own wild goose chases, and hopefully its own benefits in across the genomic spectrum.
And I mean, we have a lot of challenges in oncology with proteomics. I mean, I believe in proteomics. I think we really have to develop it. I think it's going to have to be partnered, though. But for instance, if you're looking at tumor, depending on what assay you're using for proteomics, and there's several out there right now, just handling the tumor is challenging, in that if you don't, fix it immediately, and I mean, you can get all kinds of different results just based on when you assay the tumor relative to when it was harvested from the host and processed. So, in fact, the NCI has a huge initiative that they just announced for proteomics. And basically what we're going to try to do is partner with one other institution that does it quite differently than we do, to be able to look at a comparative analysis of proteomics within the context of a solid genome-based series of clinical trials that are targeting a single pathway, so that we can hopefully understand it better. But the technology needs to be, I mean, it's out there and it's being done, but we really need to start marrying it with the other disciplines. I don't know if that helps. Yeah.
I enjoyed both talks, thank you. My question is for Dr. Green. So you asked us, well, would you have your genome sequence? And I'm like, I don't know, what do I do with this data? How do I balance the pros and cons? And so the question is, how do we manage this data as consumers? And first, a concrete suggestion, maybe naive, is whether in the report you can put a column that would say, in some scale, how much I as a patient have control to modify this, because that might help me, to do the things that I should be doing anyhow, like eating less and exercising more, rather than having the percentages without knowing what to do with it. So that's a concrete suggestion. Maybe you already thought about it, probably. And then the more general question, it seems to me, might not be specific to genomics, it's maybe true in medicine too, but this is a special case where you have a lot of data, and how would clinicians and patients best organize it and use it?
Sure. Excellent questions. So your number one sort of suggests almost an actionability scale that could tell people on some sort of scale how likely it is that they could change their outcomes. That would be a great idea, and I haven't thought of it, but it's actually hard to know. It would be the crudest of estimates in almost all types of arenas. There is a scale that they have put on. I actually was one of the people who suggested this. I'm sure there were others, but they put on a scale of stars, you might have seen on my slide, that showed 4 stars if it was really well-established information, and 3 stars if it was a little less established, and 1 star if there'd only been a single report or something. So they do, in direct-to-consumer genomics, they do try to give you a flavor of the... But, the bigger question is really managing uncertainty, managing ignorance, managing an evolving knowledge base. And it's something surprisingly doctors are not that great at. We don't like to say, sorry, I don't know. We don't like to say, I can tell you that you're at increased risk, but I can't tell you how much increased risk. We don't like to say things like that. But just to quickly respond to your second point, which I think was, how can data that's being gathered in the patient-physician context be harnessed for the betterment of mankind? And there are actually initiatives like Patients Like Me, where they are encouraging people to talk about their anecdotal evidence and combine it. It's all these kind of things are very vulnerable to people's preconceived notions, to their misunderstandings and so forth. But you're right, there's got to be a way to better marshal the enormity of clinical experience back into the research enterprise.
Yeah, if I can follow up briefly. So in the first part of the answer, I appreciate it would be the crudest of the methods and the most uncertain. But whatever you tell me or the medical community tell me is going to be more than what I have as a patient, right? Because I see that I'm 3 times more likely to die of a strange thing that I see there. But I have no idea whether I...
Right. Well, the other problem with this is that, and my whole problem with the term actionability is that it's all very well, but nobody can agree on it. So we did this research study with Ingrid Holm in which we actually gave people lists, and we said, so would you like to have a list of things that you can treat versus things you cannot treat, childhood versus adult onset, and really bad, nearly fatal versus kind of trivial. And they all made their choices, and then we showed them the diseases that we weren't going to show them. And they said, well, wait a minute, I want to know about those too. I want to know about these too. So one of the take-home lessons was that people have very idiosyncratic and personal notions of what actionability means. You might say, I'm going to prepare my children for my immediate and unreconcilable death, and that's an action. You might be Sergey Brin, who found out he was at risk for Parkinson's disease with a genetic variant like ApoE for Alzheimer's. He poured millions and millions of dollars into Parkinson's research. Is that actionable or is that not actionable? I don't know. It's probably going to help. So I think that the whole notion of medical actionability is very parochial and has sort of damaged the debate a little bit.
First, I want to thank you so much. I learned a great deal in a short period of time. I'm not a scientist, and I did learn an enormous amount, and I want to thank you also for your evident dedication and commitment to improving human welfare. As a historian, I have to think about the regrettable history of eugenics movement. I'll accept Dennis's invitation to ask you about the ethical implications. In particular, the knowledge about an individual's genetic or genome sequence, or the knowledge that can be aggregated about however you want to identify them, different groups in the population, how that we know from the past can be misused by policymakers. You don't have to be a George Orwell to think up those kinds of misuses. So I'm sure that this is the kind of thing that you think about, and I'd love to hear what you think about it.
Well, I'll just respond very briefly, and Pilar really should respond to this. She's thought about this a lot more than I have, but yes, those we should never be cavalier about the potential for discrimination, for misunderstanding, for misuse, for prejudice, and I suspect we will confront some of those things with genomics, and I'll stop there. Pilar, do you have a comment on her comment? I mean, I don't mean...
I get a chance to talk for
All right.
45 minutes, so I'll wait my turn.
It's interesting because I did a debate at the Smithsonian, and I debated a legal ethicist, Susan Wolf, and she started the debate with examples from the past, Tuskegee and, experimentation in Nazi Germany. And I was like, whoa. Okay, I think we can all agree that was bad. Now let's talk about genomics today. I mean, I think we don't want to get so used to it and so cavalier that we forget these lessons. But on the other hand, what we found in our research is that there is a remarkable amount of self-selection going on. I would never in a million years say to everybody in this audience, you must learn your ApoE for a risk of Alzheimer's disease. That's very different than saying, if you choose to learn and you have a reasonable understanding of the risks and benefits, you should be able to get that information. So, I think imposing information on people is one of the ways in which we could start down that terrible path, and I would be very much against that.
If I could just
Please.
add quickly, one of the things that occurred to me as I was listening to both of your presentations is how much your research, the FDA notwithstanding, has been facilitated by taking place within an American cultural, political, social, and economic context. And I was going to ask you whether there are other countries that have the same kind of robust investigations and breadth of investigations in these questions. But we do have the advantage of having an open public sphere in which reservations about genomic sequencing can be voiced. But what happens if this doesn't occur in a similar cultural, political context? And I realize that's a longer question than you probably bargained for, so I'll just...
No, I was asked to comment the other day on a company that was selling a pharmacogenomic product in China. It was reasonably rigorous product, but there were real concerns whether the socioeconomic constructs within the doctor's offices in their intended markets were such that they would be reasonably used or unreasonably used. And I wouldn't have that same concern at point-of-care markets, especially the vertically integrated ones here, like the Kaisers and the Geisingers here in the United States. So it's a very valid issue.
I mean, I can say that there are some countries that are ahead of us in terms of oncology and genomic sequencing. In France, there are many institutions that have teamed up, funded by the federal government, to sequence tumors and treat them, and I think it's really helped them in terms of advancing clinical research. I mean, there's programs in Canada in terms of genomic sequencing. I was just reviewing the Princess Margaret program 2 weeks ago, but there's even larger projects through the government agencies to sequence. So in terms of tumor sequencing, there are some countries that are actually ahead of us in terms of how they implement it and what they do with it, especially those countries that don't have as many drugs approved for commercial use, because it allows those patients to go into clinical trials, which is probably, not a bad thing, seeing that, less than 3% of all of our patients go on clinical trials, and we have hundreds of drugs that we need to get developed.
And before our other questioners, I'd just say that one theme I hear through the FDA and some of the ethical concerns, again, not to make light of them, I don't think we should, have this as a confrontation, but we don't seem to be talking about the cost of delay in terms of lives potentially saved. Yes, there's certain costs to rushing things and rushing into things without an appropriate evidence base. There's certain risks in rushing into things without appropriate regulation or thorough regulation. But there is a balance here. Some of these things are really going to save lives, and when we delay them, sometimes for very good reasons, sometimes out of fear, we are delaying their benefits.
Oh, absolutely, especially when it comes to oncology. Yeah?
Oh, okay. We're all going to defer to each other, so I'll start out. Again, thank you for the wonderful talks. I want to ask about what Robert called, if I recall correctly, the problem of penetrance. But it might be something that Barbara wants to comment, that Patricia wants to comment on also. So I take it that the problem is, crudely, that in one person, a bit of DNA recognized as a disease gene will cause a disease phenotypically, and in another person, the same bit of A's and T's and C's and G's won't.
Exactly.
And so I want to check if I understood what you said afterward. You then said that this should be an invitation to introduce a new kind of disease taxonomy, which would be molecular. And one way of understanding that is that one would learn that you have, let's say, BRCA1, that you have breast cancer in potentia. But it strikes me that there would be another way of looking at it, which is to say that it's not enough to know that you've got that strip of DNA as to whether or not you have breast cancer, and that the richer taxonomy we want will be about the range of genetic backgrounds and the range of environments in which that particular strip of DNA will cause breast cancer.
Beautifully stated. I totally agree.
So I was just writing down my thoughts so I wouldn't forget them, but you know, we are moving more and more towards molecular classification and not histologic classification. And I'm not 100% in agreement with the pendulum going totally the other way. So if you have BRAF mutant melanoma, you'll respond to vemurafenib, which is a BRAF inhibitor, or dabrafenib. If you have BRAF mutant colon cancer, you won't. So, I mean, if you have KRAS mutant or KRAS wild type colon cancer, you're treated differently than if you have KRAS mutant or wild type lung cancer. So it's important to know the molecular classification, but we can never forget where the tumor came from. So, and that's one thing that, you know, as you were asking that question, I think it's very important. The other thing is, you're very right. All that's BRCA mutant in terms of germline in human beings is not created equal. So what makes one patient, so when I gave a talk on incidental findings at the Institute of Medicine about 1.5 years ago, and, you know, it was about, what do we do with incidental findings as a, because we're doing a lot of profiling these days. And probably the most common reported incidence of BRCA mutation being found as an incidental finding in the literature is from patients that have been profiled germline that had pancreatic cancer. So you're right, and I mean, if you look at my own family, my niece was diagnosed at 30 with triple negative breast cancer. And so they thought, it's just a sporadic fluky thing. And then her sister was diagnosed, my other niece was diagnosed at 23 with triple negative breast cancer. 2 siblings with the disease. And when they went and interrogated, it was BRCA mutant, but it was from the father, who never manifested any disease whatsoever. So why the dad didn't get anything, but 2 children did, and both sons are refusing to be tested. And they both have children. So you're right. What triggers that one BRCA mutant to develop ovarian cancer, and the other BRCA mutant to get breast cancer, and the other one to get pancreas, and then maybe 5 more to not get it at all within the same pedigree? I don't know. I mean, I don't know if it's environmental.
Those other omics, it's environmental, but it will be you're right, it's more than a taxonomy of molecular alone. It's a taxonomy of the complexity of modifying elements.
But I think the beauty is we're now developing the tools, and we're starting to have the tools that are going to hopefully help us understand that I don't think there's going to be 2 cancers created equal.
So I have a question for each of you, and my first one is for Dr. LaRusso. You mentioned that in a really very complex trial that you helped to develop that you weren't allowed to do combinations, that FDA didn't permit you guys to do combination therapies. Could you talk about more about that? What was their
Yeah, absolutely. No.
Are there ways now that you've been through this to think about how to design
Yes.
trials?
Yeah, so basically, this trial has been a labor of love. If you can just imagine, it's taken a lot of energy. And we were grossly underfunded to do the trial. We only got $6 million to do many different things within the context of this grant. And if you put it into comparative analysis, the MATCH trial at the NCI is well over $100 million. The signature trial, which was done by Novartis, was $125 million. So, I've had to write 6 additional grants to support one grant, which is, pretty frustrating. A lot of work. But the deal is that they allowed us to only treat with drugs or drug combinations for which there was a recommended phase 2 dose. So I have a personal interest in melanoma. That's why I went after the grant. Never wrote a paper in melanoma in my life before, but I did go in with Jeff Trent, who had done a lot of work with melanoma when he was at the NIH with Steve Rosenberg. But, we were very fortunate that we got this grant. And when I went to the FDA with it, I wanted to do combinations. They said no, because there hasn't been a recommended phase 2 dose. Putting a lot of targeted therapies together is toxic. So if you put MEK and CDK together, you can do it, but it's relatively toxic. But I don't know. In some ways, I think we could circumvent it by doing sequencing, but I would have to go back and amend the protocol massively. And there comes a point in a clinical trial where if you keep stalmating it, it's going to become too old to want to recruit patients to. So what we've decided to do instead was just to look at it within the context. Every patient has the capabilities of having PDX models generated, and now we're also generating them in immune models so that we can look at drug combinations. But you're right. The ideal thing is to at least sequence, but we didn't put that into the context of the trial initially. Yeah. No, it's tough. Because every time we have a telecom, which is every week, we present 2 to 4 cases on our molecular tumor board. You get really frustrated that you can't deliver combinations. I would say 90% of the patients, we would have recommended combinations. Yeah. So are you even going to get a benefit long term? I don't know. It's a randomized trial because without those combinations, I don't think we're going to be faring any better than the standard of care arm. But time will tell. And you will never know the truth about the combinations. Yeah.
So I have a quick question for Robert. You made a comment about genetic exceptionalism, and I agree that there have been a lot of different attempts at various kinds of screening that either that generally weren't justified with a good level of evidence, and that's everything from PSA testing, the number of completely asymptomatic men that we have tested, or whole body scanning or whatever, right? There have been a lot of things, and in many cases we're starting to dial it back because we're actually seeing a lot of harm and potentially more harm than benefit. So I guess my question to you in terms of thinking about reporting back incidental findings and framing that as a kind of screening, right? There are all kinds of guidelines out there in the world about when we should do screening, and most of them include things like there are good secondary confirmatory tests, and there is something you can do to intervene to create benefit. And so do you really think that this is some kind of genetic exceptionalism to where we're holding genetics to a higher standard, or is the problem that we've gone forward in a lot of cases when we shouldn't, when they didn't meet existing standards?
Well, I think it's a little bit of both, but I think we do hold genetics to a higher standard, and It is for all the reasons we've been discussing, the historical ones and the ones that have been mentioned. I was a little glib about our incidental finding recommendations. Pilar, as you probably know, we really did try to select a minimum list that there were, in general, ways to confirm the predisposition or at least the early symptoms of the condition, such as EKG or heart monitoring, and there were, at least theoretically, treatments to prevent them. So we did pick those 56 genes and 24 conditions with those criteria in mind. But as you also know, Baylor and other places are giving way more back than the minimum list. And I don't think it's going to be possible to hold back the tide of industry and DTC, which are going to be promoting the screening. So I think screening, and I'm a little undecided about how much of this is a good idea or a bad idea. I think that our criteria that we've all agreed upon for public health screening has a huge social equity and economic component in it, which I respect. But these entrepreneurial companies are actually selling something different. They're selling it to people who can afford it and who want to not only buy into the possible narrative of health benefit, but also a certain insight into themselves. So it's a hybrid of public health screening writ narrowly and a kind of entrepreneurial information science which celebrates the empowered self and the quantified self. And I think, therefore, it's a slightly different animal, and it's not quite fair to hold it to the same standards we've been thinking about when we talk about newborn screening and colonoscopy and so forth.
Yeah, but the one thing there is that when an incidental finding is unveiled that they have to have further work of, the burden will be on the healthcare industry. And the question is, how much of that? But then the study needs to be done by a great, Masters of Public Health epidemiologist to outweigh the costs of screening with incidental findings versus, and you'll need a financial person as well, versus the cost of treating those potential diseases long term. The problem is in between, what's the percentage of those incidental findings that would ever come to fruition?
The problem of penetrance again.
Yes.
Exactly.
And that's where the extreme cost is. If you could dive further and define exactly who's going to have it, it would be one thing. But if it's only going to be 5% of everybody that manifests that gene, it's going to be extremely expensive to screen 95% of people for 5% that are going to get the gene.
And by the way, about 1% of people have a pathogenic variant in the ACMG56. So that's just 1% of people.
It's a lot of people.
Now, would you be surprised to know that about 500 Framingham individuals who were sequenced, I was able to go back and look over a 20-year period at the 5 of them, exactly 1%, who had positive mutations in the ACMG56. Would you like to know how many of those 5 manifested the disease that they were mutated
Over what
for?
time period?
20 years.
60%?
80%. 4 out of 5.
Wow.
Very small sample size, but I did the same thing with another 3,000 people who were cross-sectionally evaluated. The percentages were much smaller, but when you modeled that against the people who did not have those mutations, there was still a highly significant difference.
We have time for one last question.
Thanks so much. I wonder if you'd be willing to say a little bit about the relationship between genetic and genomic information and kind of discussions around personal responsibility for health. On the one hand, it seems that when people have a genetic explanation for disease, then it sort of relieves them of responsibility, right? It's not my fault that I developed this or that. I had a predisposition for. And on the other hand, there's a large conversation around the obligation to obtain and use genetic information. So there's a debate about whether people should be allowed to refuse information, right? The so-called right to ignorance, as well as a whole literature on responsible parenthood and the obligation of potential parents to use that information to prevent passing on variants. So there seems to be a tension in how we use genetic and genomic information and the conversation around responsibility for health. So I wonder if you might say something about that.
Yes, so that's a huge ethical issue. I mean, and I don't know that anybody can really answer a lot of those questions. But I think without genomic testing, we all know that smoking and obesity leads to greater increase of heart disease, cancer. So why are we not saying that regardless of a genomic profile, every human being has a moral and ethical obligation to lose weight and stop smoking and stop drinking? I mean, think about it. Do you need genomics to be able to help you solve many, many different things? So I don't, I mean, that's really, really tough. I mean, you know, one thing that does drive me crazy is when there is a parent, and, you know, we have a huge, you know, prenatal program, and, you know, we know that these parents are harboring, you know, a germline that's, you know, dominant, and you know that the baby's possibly going to get it, like Huntington's. But a lot of them will still have kids, and if their brother had Huntington's, they don't want to be tested so that they don't know because they just want to have kids. But then you have the extreme, you know, like that they're afraid to have kids because even though there is no genomic testing, their brother and mother and father died of a disease, so they've elected to not go that route, so they're not held liable and responsible for any disease that their child, you know, those, I don't know that anybody, they're so personal, and I think that there should be an obligation that they have a religious component to those thought processes within each individual, whether or not they want to face it. But I don't know that there's a right or wrong answer.
Yeah, I think we're almost out of time, so I'll just
Yeah.
say you raise really good points. And from my personal opinion is that we have actually, I mean, you raise them about genetics, but they're true about many issues. And that is part of the genetic exceptionalism that I think personally has pushed too far in the direction of genetic exceptionalism. These are critical questions for human life across the board, and they're not that fundamentally different in genetics than anything else. Anyway, thank you very much for your attention.